Thank you so much for having me. It's nice to talk to you all today. Can we get started? Yeah. All right. So thank you again. Today, give me one sec. There we go. Okay. So today we're going to talk about, as Dr. McNeely mentioned, something that's become very interesting to me over the last decade, given my experience. We're going to compare the US and the Canadian systems. We're going to talk about a common pediatric urologic problem, UPJ obstruction, its presentation and management, and then within kind of management, robotic and laparoscopic approaches, which will tie into our first point also. So starting at the top, aside from having great coffee and pretty money that you can't tear, which the novelty of which has not worn off for me, by the way, people are always drawing comparisons between Canada and the US. So is the grass really greener here or there? And if you ask somebody, I mean, everybody seems to have an opinion. But how do you sift through those opinions? At a time where misinformation is at an all-time high, there's a lot of noise, and everybody thinks they're an expert. So I guess before I continue, I should say that I'm not an expert. This is based on my, observations, experience, and some research. So let's start with why the heck am I interested in this? Well, starting at the beginning, as Dr. McNeely mentioned, I was born and raised in Hamilton, went to medical school in London. Shout out to Ben Chu. Went to McMaster University for urology. I think Soo Jin's in the audience too, so shout out to Soo Jin. And then did my fellowship at SickKids. And then through a series of unlikely events, ended up in Palm Beach, Florida. And for those of you that don't know, Palm Beach is one of three main counties in South Florida, and it's almost considered within the state like its own little country because it's so very different from the rest of Florida. And here's a picture of where I initially moved to, West Palm Beach, Florida. I don't have a cursor, but across the bridge, there's a yellow building. That was the condo that I had moved into when I first went there about 7 years ago. And you may be familiar with some fine, upstanding citizens that also live in Palm Beach, Florida, such as Donald Trump, Kid Rock, Jeffrey Epstein, and one that I'm actually proud of, Celine Dion. So let's start with a comparison of the systems themselves, the structure of the systems. And I know I don't have to tell you guys, of course, you know that the Canadian system is a universally publicly funded system where all citizens and permanent residents get coverage for medically necessary services at no cost, when you show up. Compare that to the US, which is a lot muddier. There is a mix of public funding, a lot of private funding, a lot of it is for profit, some not for profit, and public care is not an option for everybody. You really have to be over 65, a veteran, very low income, disabled, or minors. Minors get covered very well, actually. Most people are covered by private insurance, and you can, since 2010, since Obamacare was introduced, you can buy private insurance through the Affordable Care Act, or the way most people get it is through their employer. And if you go the employer route, it's typically a subsidized premium. So you're still responsible for some of the premium costs. And I mean, they pride themselves on choice, but there are hundreds of plans and they're all so different and so variable. It's extremely confusing, even for somebody, like me, educated in the system. There's a lot of options and many of them are not very good. And despite being insured, in most cases, there's still a cost at point of service. The hospital systems also function very differently. In Canada, as you know, they're either publicly owned or not for profit, and they operate under a global budget, which has a lot of implications for surgeons like us, because every case you do eats at that global budget. Physicians are mostly self-employed and fee-for-service, as you know, some salaries. And as physicians in Canada, we're the primary gatekeepers deciding what service is appropriate, whether it's indicated, and so on. In the US, the hospitals, again, very muddy. Some are public, like the VA. Most are private for-profit. Some are private not-for-profit, but they're generally kind of all corporate-owned. Hospitals get money for every service they provide. Sometimes it's just a daily fee, and sometimes it's a completely itemized bill. So really, they're very incentivized to get as much volume through the hospital as possible, especially if you have insurance. Physicians are self-employed, although that's becoming the minority of physicians nowadays. Many kind of go into groups where they can better negotiate contracts with insurance companies. And what's becoming more and more popular is, big corporations, hedge fund type organizations buying practices and managing them. So physicians become basically corporate employees. Payment or reimbursement is based on contracted rates with individual insurers. And there's, like I said, hundreds of plans, and every provider or hospital has a different agreement with each of those plans as to what you'll get paid for a particular service. So it's complicated, and it's difficult to get paid too. And in contrast to Canada, where physicians kind of tend to have the final say as to whether something is indicated or not, in the US, insurance companies have a lot of power in that realm. Almost everything requires a pre-authorization. And if somebody, reviewing the paperwork, the insurance company says, this patient doesn't need this, well, it's a really big fight as a doctor to prove to them that indeed your patient needs it. It's no secret that the cost of the systems are very different. So let's look at some numbers. In 2021, from CIHI, the cost of, or spending, I should say, for the Canadian healthcare system was $308 billion, which represents 12.7% of Canada's GDP, which works out to about $8,000 per capita. In the US, $4.1 trillion, which is 20% of GDP. Of course, they have a higher population, significantly higher, but it still works out to over $12,000 per capita. But despite these astronomical costs, there's still a large number of Americans that don't qualify for insurance or can't afford it. Now, this has gotten better since Obamacare was introduced. The number used to be closer to 20%. But I mean, that's still very high. So with the higher costs, does that translate into better outcomes? And health outcomes are difficult to measure and compare. When I was trying to kind of find, good ways to compare the two, it's very difficult to get data. But one way to look at it is to look at mortality rates. And here we're comparing the US, Canada, and the OECD countries. And that represents a group of 38 countries that kind of compare data and benchmark statistics, population statistics for comparison. So the only point where the US exceeds both Canada and the average within the OECD countries is in cancer mortality. In all other measures, they're falling behind. So, as a patient, let's say, where would you rather get sick? Where would you rather be? So let's switch gears a bit and use a case to kind of put it in perspective. So this is the case of a 9-year-old boy that I treated last year. The story is he was riding his bike, fell off, hurt himself. Parents were anxious, took him to the ER. He was saying his side hurt. The ER doctor did a renal and bladder ultrasound. He had no gross hematuria or any other kind of obvious injuries at the time. So here are pictures of his ultrasound: right kidney, left kidney, and bladder. And during the course of his time in the ER, he ultimately started feeling better. There were no other symptoms or hematuria. It was deemed to be an incidental finding that was probably there before he fell off his bike. Not sure, because there's no baseline. And so outpatient follow-up was planned in my office. So I see him a week later. He's otherwise healthy, but there's this funny history of recurrent pain and vomiting, to the point where they were referred to a pediatric GI who did an endoscopy that was normal. One of the great things about our practice is that we have ultrasound in the office, which we can do ourselves. And it's great because really you learn a lot in holding the probe kind of, I always say you understand kind of the angles and what you're taking pictures of so much better. So anyway, I did an ultrasound and the kidneys were normal. He, at this point, had no symptoms. So you start to wonder, is it an intermittent UPJ? Or maybe there was some other random event, maybe he passed a stone and now the kidney's normal. Hard to say, but we said, okay, we're going to keep a close eye on you. If the pain happens again, let me know. So 3 weeks later, he ends up in the ER again with nausea, vomiting, and pain. The ER doctor does an ultrasound again. So it looks a lot like his first ultrasound. There's the AP of 2.58. Left kidney was normal. At this time, they said, well, he's kind of behaving like he has a stone. So let's make sure that there's nothing acute blocking the ureter. So I don't have any good picture of the ureter, but there was no stone, and the rest of the ureter was normal, but there was significant hydronephrosis of the right kidney on this non-contrast CT of the abdo-pelvis. In the meantime, he got better. We said, okay, let's come back to the office and let's make a plan. I repeated his ultrasound again, and here are the pictures from that visit. It was normal. He was asymptomatic again. So I said, let's do a LASIK scan. Let's see if that can maybe trigger the pain or the hydronephrosis. So here's the pictures from that. And I usually have them put a catheter in the bladder, and for some reason it wasn't working very well in this case. So there's a big bladder, but that aside, you can see that on the right side, it really doesn't look like the kidney's draining very well. The function is preserved, and the curve, or the T-half, isn't, slam dunk impressive. But what's interesting is it was slow, and he had pain during the test that was exactly like his recurrent episodes. So we decided to proceed with a pyeloplasty. In this case, I chose to do it robotically, and we'll talk more about that in a minute. I as a matter of habit, do a retrograde pyelogram. And these are his pictures. So we ended up doing the pyeloplasty. I always put a stent in that I leave for 6 weeks. It looks like a crossing vessel, but it actually wasn't. His repeat ultrasound after stent removal showed some residual hydronephrosis. It's now been about 3 months. He's feeling good, and our plan is to continue to follow him with ultrasounds and then repeat a LASIK if he becomes symptomatic or his hydro starts to look worse. So UPJs in general, in this case, he presented symptomatically. That's less common. It was first described by Dietl, and so we call it Dietl's crisis. More commonly now is the asymptomatic kind of antenatally detected hydronephrosis. I always have them confirm, or I always have them come to the office, and I confirm on an ultrasound a week or two later, because it can look actually significantly worse out of the newborn period. And ideally, you get a MAG3 when they're at least a month old, and that helps determine if it's obstructive or non-obstructive hydro and whether there's been a hit to the kidneys. In some centers, they're doing MRUs. I've seen beautiful pictures. I don't have access to that. And of course, retrograde pyrelography, which gives you a different view of things, but involves anesthesia. The assessment of hydro has changed recently. In our case, it would be an SFU3 or a UDT2, P2, but this is usually your starting point. And how do you decide which ones need intervention? So you got to figure out which ones are blocked. So this is the official definition of a blockage. Peters refined it a bit and said if there's already, a loss in function, that should make you a little more apt to intervene. In general, for me, worsening hydro, worsening function and drainage on serial tests, symptoms would be triggers. And so there are varying approaches to pyeloplasty. The classic, of course, being the dismembered pyeloplasty, which can be approached different ways, and we'll talk about those. And then there's various flaps that can be done without fully dismembering, and endoscopic techniques. Here is the classic pyeloplasty that we all know. The open is still, I believe, the gold standard. Laparoscopic was introduced in 1993 and can be done either transperitoneal or retroperitoneal. And then since 2000, the robot has really gained a lot of popularity in the US. This database review of a lot of patients found that over the course of 12 years, the number of pyeloplasties are actually going down, and they think it might be related to the birth rate going down. I don't know. But interestingly, open pyeloplasties have gone down by 10%, lap by 12%, and robotics up by 29% annually during that time. In fact, in 2015, robotic pyeloplasties accounted for 40% of cases in this group in the US. It was mostly geared towards adolescents, which makes sense. The open approach is still favored in infants. And interestingly, when they first introduced the robot, they said, oh, well, now it's very expensive, but over time it's going to get cheaper. Well, they didn't find that it did over this study period. One of the first and a very good meta-analysis comparing the three approaches was published in 2013. They didn't find a significant difference in success or complication rates. The length of stay was shorter for the robotic approach compared to open, but was similar for lap, which makes sense, given that the robotic and lap are basically the same operation. They found that operative time was longer for the robotic compared to the open approach, but was similar for robotic and lap. And this is kind of maybe earlier in the robotic experience. The cost, no surprise, was higher for the robotic. There have been since then other reviews, and I'm focusing on these meta-analyses because there's just a lot of kind of observational studies out there. And so this is a good way of pooling the data. In this one, it was significantly later in the experience, so 2019. Not a big difference in success rates, and they only compared robotic and lap. Complications, not very different. Operative time, interesting, was not very different because one of the supposed benefits of the robot is that it's easier to suture, which makes it faster. And the length of stay was shorter for the robot, which is also a curious finding. But cost was not discussed. The most recent was kind of just a review of all of the data out there. And in this one, they found it favored robotic for complication rates, operative time, length of stay. And they said based on a study, which I'll go over in a minute, that the cost was not significantly different either. What's interesting, which makes you doubt the data in general, is the length of stay. I mean, 4.6 days, 5 days for a lap pyeloplasty is very long. Same thing for robotic. 3 days sounds very long. So the data isn't great, I guess, is the takeaway. Robotics have been performed in infants, and the differences or the gains or benefits are reported to be less in this group as compared to the older kids. This study looked at costs specifically, and their claim is that because the operative time is so much shorter for robotic cases because of the ease of suturing, it compensates for the increased direct costs. What they couldn't really extract, though, was the upfront capital cost of the robot, which is in the millions, and then the ongoing costs of maintenance. That, because all of their resources are pooled in the OR, they weren't able to extract that. So you can take this with a grain of salt, but many people are quoting this as a reason to pursue robotics in the US. There was one randomized study comparing lap to robotic, and it was a single surgeon that randomized patients to both approaches. So it might be kind of the best way of comparing, somebody who's really good at both. And he didn't find a significant difference in outcomes. I highlighted the lines in the table where he did find a significant difference, and this was an operative time was slightly longer for the lap approach, fewer trocars for the lap, and they are smaller trocars also. I mean, the robotic, even the new XI is, you need 8 millimeter incisions. And for the lap, you can get away with 5. The cost, he also found, was significantly higher for the robot. And then, interestingly, he had 2 redos in the lap group, but he didn't really go into detail about why. This apparently wasn't significant, though. So, going back to our question of comparing the two, where would you rather end up? There are definitely, and these are my kind of opinions and lists here. There are definitely pros and cons to both. But let's go back to our patient and think about it, if you're going through the system, what are the steps? So in Canada, as you all know, and we'll do a simpler example, I should say, than my patient who ended up in the ER so many times. Let's say you present with the standard antenatal hydronephrosis. Now, to get into a specialist in Canada, you need a primary care referral. That's sometimes the biggest barrier, is they are the gatekeepers. So you get your consult. They decide you need a Lasix renal scan. They plan it, book it, do it. You get your pyeloplasty, your post-op visit, and then your ongoing follow-up. The only barrier is getting that initial referral. Beyond that, everything goes through your doctor, scheduling, which could be a barrier too, but truly nobody's going to block you from moving forward. In my experience at Sick Kids, this whole process might take about 3 to 6 months from presentation to surgery. And as you know, the out-of-pocket cost at each step would be 0. In the US, there's the initial referral. Now let's take a Medicaid patient or an HMO patient, and we can talk about the difference later. But just to get through the door, you need a primary care referral again. However, you also need authorization from the insurance company. You won't get into a specialist's office unless the insurance company's already said, yes, I'm going to pay you. And in our case, we always get auth for both the consult and the ultrasound that I'll most likely do. That's a process that takes sometimes multiple phone calls. You're on hold for 45 minutes. They hang up on you. You have to call back, and paperwork back and forth. I mean, we have we're 2 surgeons and 2 nurse practitioners, so 4 providers, and we have 14 office staff to support us. So let's say at the consult you say, okay, you need a Lasix renal scan. You need another auth to get that done. You go to the hospital, get it done. Let's review the results, plan surgery. Now, this is a big one, getting authorization for surgery as an inpatient. The hospital won't let you through the door unless they've already had a guarantee from the insurance company that they're going to get paid for whatever it is you think you're going to do. So you get your pyeloplasty done. The one thing included is your post-op care. So there's, for most surgeries, a 90-day global period, we call it, where post-op care is included at no additional cost. And then once you get into the follow-up loop, again, there's a referral needed again, and then authorizations for each step of the way. Even though there's more barriers, it tends to go a little quicker. I would say on average about 3 months to get through all of these steps as a patient. And then if you are on Medicaid, there's no out-of-pocket cost. But let's contrast that with a private insurance patient. So this is somebody who, say, gets insurance through their employer and has a private insurance plan. Same thing, you still need the pre-auth in most cases for a consult and ultrasound. But here, despite the fact you're paying your premiums, you still get hit with a cost for that visit and the ultrasound. And this is an estimate. Then we say, okay, we want to do the Lasix renal scan. This, because it's done in the hospital, there's additional fees for the hospital. So you're looking at about $1,500. Review the results. This one typically doesn't require another referral, but some plans do. And then for the hospital visit to get your pyeloplasty done, you again need all the pre-authorizations. But the hospital bills are astronomical, and this includes, anesthesia, the facility fee, the nursing, et cetera, and that's separate from the surgeon's fee. So post-op visit is included, as we said, and then the 3-month follow-up situation, you end up in, again, another loop where you at each step of the way have to pay some portion of the bill. So in total, this works out to about $35,000. And let's use an example. This is an example of my insurance plan. So for me and my family, we pay $620 a month premium, and that's subsidized. So my employer pays 60% of the premiums. This is just 40% of the premium. We have a high deductible. So until we as a family reach $7,000 in bills, the insurance does not pay anything. And so fortunately, there's an out-of-pocket max. So once you've hit $13,000 as a family, then the insurance kicks in. But you still have to pay 20%. Oh, sorry. Once you hit the deductible, insurance kicks in, but you have to pay 20% of the bill until you reach your out-of-pocket maximum. So it's confusing and expensive, but really it's the only way. And I'd say it mostly protects you against, disastrous type of health problems. So if you have kind of little things, you're essentially paying for your care until you reach a $14,000 bill. So these are my opinions about pros and cons from both a patient and doctor point of view. So in the US, you do have many options, especially if you have money. If you have a PPO type of plan, you can self-refer. So you can make an appointment at any specialist you want. You can, if you can get an order for it from a doctor, you can go get an MRI of your whole body if you want, as long as you can pay for it. Generally, there's a lot of idle providers and equipment, so you can get access pretty quickly. New technologies are very available. The robot is an example. so many, like every community hospital has a robot. There's a little bit more of a catering towards patients, which patients like, I think. And it's a little more personal in many cases, not always, but for me, like I know, every single one of my families, the majority of my referring doctors, we text or call each other type of thing, which I think is good for the patients too. And for kids, pediatrics is very well covered by Medicaid. So I think the kids get looked after well. Of course, there's always downsides. Insurance, as you saw just now, is very expensive and prices are high. I mean, everything is inflated. And I believe in general to compensate for those who don't have insurance and end up getting emergency care or whatever it is, prices are overinflated. There's a lot of middlemen kind of making profits from the high prices too. Coverage is highly variable. So just because you have insurance doesn't mean, you can get this service or that, or go to this doctor or that doctor, this hospital. It's very restrictive. And really insurance dictates who you can see and where you can go. It's possible to be uninsured, which is a terrifying idea, but it happens. And I found that there's a lot of variability in doctor qualifications. You can practice if you're board eligible and not board certified here. So, just because that doctor has the best website doesn't mean they're the best doctor. So there's a lot of booby traps, I think, for patients. You really have to kind of be on your toes to make sure you're getting good care. And that's stressful. There are good things from a doctor point of view. There's lots of resources. I mean, especially as a surgeon, it's a wonderful thing, to have whatever you need almost, with some limitations. There are lots of opportunities, lots of jobs, practice models. If you're business minded, especially, you feel valued by the hospital, of course, because you're bringing in revenue to the hospital. Examples are free parking. Sometimes there's valet parking. You get lunch provided. Like the hospitals I go to have like a buffet lunch for doctors every day. You develop relationships with your referring doctors, which I, like I said, I really enjoy. If you are business minded, there is a higher pay potential, I believe. And as we all know, taxes are lower here too. The downsides are that it's expensive to practice. Like I mentioned, I mean, we have, at some point we have 15 people, to run our office of 2 surgeons, basically. There's a lot of competition among doctors. Contracts dictate everything. If you're not a provider on a specific insurance plan, patients can't come to you. So you have to negotiate contracts with the insurance companies. And the contracts are variable. I mean, some doctors make a lot more than others on the contracts. And what's happening is doctors are undercutting each other because of the competition, which gives the insurance companies more power. So really, contracts with insurance companies matter a lot. There's a big move towards corporatizing medicine. And of course, it's all, profit driven, most of these corporations. So it really kind of clouds the priorities of healthcare. There's a high chance of getting sued. Everybody's looking for mistakes. And patients, they do have a little bit more entitlement. So I see a chat thing here, somebody, but I can't open it. I'm going to keep going. In Canada, as you all know, of course, there's universal coverage. I mean, you can't beat that as a citizen, as a patient, or as a person, just to know, that you're covered. You won't be restricted from going to one hospital or another, or one doctor or another. When you show up, you don't have to shell out any money. In general, my experience, the baseline quality of doctors' care is better. I think because there's more uniformity in training and credentialing. So that's reassuring from a patient point of view. I think, this can be both a good and a bad thing, but in general, there's a lot of unnecessary tests done in the US just because you can. And I think that can have a lot of downstream effects. So fewer unnecessary tests, I think, is a good thing for patients, and more consistent follow-up. People don't move around so much. They don't doctor shop so much. And the downsides, of course, everybody in the US will tell you this: wait times are slightly longer for elective things. Drugs aren't covered. It's less of a consumer-oriented type situation or encounter, doctor-patient, there's a big dependency on primary care doctors to get patients in and followed, and that puts a lot of strain on the primary care network, I think. So you have less access to specialists, and maybe that's a good thing too. And if you did want to pay, let's say you were some bazillionaire, you don't really have those types of options in Canada. As a practicing doctor in Canada, and you guys can help me out with this one too, there's less of that competitive vibe. People don't move around so much. Jobs are a lot more stable. They don't come and go like they do here. The fee schedule is fixed and predictable, as opposed to having 100 different contracts with 100 different insurance companies, and maybe only getting paid 20% of your bill. In some cases, doctors have pensions, overhead to practice is lower, and you don't have to deal with the insurance companies. If you say a patient needs it, he needs it, and you move forward. It can, I'm sure, get frustrating. I remember I locumed before going to the US, and I remember kind of having cases canceled because it was close to 3 and there was no nursing. And so, limited resources or OR time, I think, is from a surgical point of view, sometimes a struggle. There's not as many jobs. Population's a lot less, of course. The fee schedule is fixed and controlled. And if you are business-minded, there are kind of more limited practice type models. And of course, taxes are higher. So after all of that, where do we end up? Is the grass really greener here or there? And I came across this quote when doing my research. And I think it's kind of true, is that, for every benefit, there's also a downside. So where does that leave us? There's pros and cons to both systems. From my point of view, that universal access is really, it's invaluable. It's I think one of the greatest things about the Canadian healthcare system, and the US, despite all of its benefits, doesn't come close to that. And then going back to our case, and this is again a bit of my opinion infused in here, robotic pyeloplasty does have some advantages, especially if you can't do it laparoscopically. But if you're good laparoscopically, I don't think that the expense outweighs the benefit in most pediatric patients. Especially in very small ones where you can do a beautiful open operation. So that's all I got. Thank you so much.